Welcome to the Emergency Medicine Cases podcast. I'm your host, Dr. Anton Hellman, bringing you the brightest minds in emergency medicine from around the world. EM Cases is brought to you by SHREMI, the Schwartz-Reisman Emergency Medicine Institute. That's a nonprofit organization dedicated to improving EM care through high-quality research and education. The opinions expressed on this podcast are intended for information and education purposes only and should not be used to diagnose, treat, or prevent any medical condition, nor should they be used as a substitute for medical advice from a qualified practicing physician. Emergency providers need to be masters of the undifferentiated patient, right? We need to prioritize. We need to tolerate uncertainty. We need to be resilient. We need to manage complexity. We need to continuously risk stratify our patients. We need to juggle a dozen patients in a discrete period of time. And we need to know how to combat decision fatigue and cognitive overload. We need to be intentional about what we do before, during, and after a shift, so that we're prepared and agile and maximize our performance on shift. Now, whether you believe the famous Time magazine article that claimed our attention spans are only 9 seconds, no better than a goldfish, our attention spans do seem to be diminishing with every passing decade. At least that's the way I feel about my attention span. So how do the master clinicians do it? How do they think, prioritize, and manage complexity in our chaotic work environments? Well, I have the privilege and honor of having 3 master clinicians and deep thinkers on EM Cases. My close friend, who you've heard on EM Cases before, from Brooklyn, New York, born and raised in Texas, trained in Montreal and New York, an EM educator with an amazing algorithmic mind. Check out emupdates.com. And also a passionate basketball player I've learned more recently, Dr. Ruben Strayer. Welcome back to EM Cases, Dr. Strayer.
Thank you, Anton. After decades of competitive basketball, my knees have given up and I'm rapidly heading towards unwilling retirement. But other than that, it's great to be with you and this crew of really good-looking men.
Well, hopefully you'll find a good pivot to another sport that will be just as satisfying. And another good friend who graciously hosted me in Calgary, where he works as an emergency physician. He makes probably the best cocktail I've ever had. He was the medical director of the STARS Air Ambulance Service, which inspired EM Cases' Crit Cases blog. Check it out on EM Cases' website. That's with Mike Mesh. He's known in the Canadian EM community, I would say, as EM Ninja for his master clinical skills, and he's an avid mountain biker as well. Welcome back, Dr. Betzner.
Many thanks for having me. I look forward to the discussion today. Should be interesting. Good to see you guys.
Great. And a man who really needs no introduction at all, also a friend and a huge inspiration to my podcasting, ED intensivist, the brains behind MCRIT, fellow podcaster, and many of you might not know, he's actually rumored to be an incredible chef, Dr. Scott Weingart. So great to have you back.
Hey, pleasure to be here again, Anton. I'm concerned, Mike. A ninja is actually an assassin. Isn't that a problematic thing?
I did not come up with that. I don't know where that came from, but yeah, I would agree. That would seemingly be not so good for my patients.
All right, here's the framework for this podcast on how the experts think. We're going to start with what you can do just before a shift to prep yourself for a successful shift. Then on shift, we'll elicit some high-yield tips and tricks to stay sharp and focused in the ED. How to deal with distractions, interruptions, dealing with decision fatigue and prioritizing, etc. Then we'll talk about how these experts think about a resuscitation and what to do if things go sideways or your mind freezes during a resuscitation, and then you end up being stuck in that abyss of non-action. Then there's the complex non-resus case, where we'll find out how these gentlemen gather data, how they analyze it, how they go about cognitive debiasing, how they deal with risk, and how they deal with communication adversity. And of course, how we think is important outside the ED as well. So in the last part of the cast, we'll go through a potpourri of strategies to practice outside the ED to improve the way you think and act when you're in the ED, because we can't really expect to think like a master clinician without putting in some extra work when training outside of work, even if we're veteran emergency doctors. So this cast, I think, will likely be divided into 2 full-length podcasts because we have an enormous amount of ground to cover. So let's jump in and start with what we can do just before your shift starts. Now, it's important to have not only your body, but your head in the ED when you arrive at work. So the question is, how do we best mentally and physically prepare for an ED shift? Now, we covered a lot of this stuff on episode 134, Shift Preparation and Pre-Gaming with Rob Orman. And on that podcast, we talked about sleep hygiene, power naps, casino shifts to preserve circadian rhythm, eating protein-rich foods, doing high-intensity exercise workouts just before your shift, taking a cold shower to wake up, listening to a medical podcast to get you thinking in a medical frame of mind just before your shift or on your way to work, and maybe listening to an inspirational song to get you pumped just before your shift, creating and sticking to a ritual just before your shift starts, reminding yourself of the purpose of being an emergency doctor in the first place, that privilege of being a doctor and what you're grateful for at work, positive self-talk, and then saying positive statements to your team to get them pumped as well to do some kick-ass work. Let's start with Dr. Betzner on this one. How do you prepare for an emergency shift? In other words, how do you clear your head so that you're going to be a master clinician at work?
Well, there's a few things. One, I try to ride to work as often as the weather will allow me to. Even when it's cold in the wintertime, I usually ride to work and back, or try to. So you're thinking about, other things than work when you're doing that. It clears the mind. I used to ride motorcycles for the same reason. It just clears the mind. Well, I also, when I get to work, I always set up my office. I have a rolling office now that's getting quite out of control. People laugh at me, but I have this desk that I roll around the Emerge with 2 screens, my laptop and an iPad that are connected, and a bag full of everything you can't find in the emergency department. I have in my bag everything. So I'm never looking for anything. Anyway, I set it up exactly the same way each time. The apps are open the same way. Everything's set up the same way. And finally, I actually always start my shift 30 to 45 minutes early. And the reason I do that, before students are there, before residents are there, I don't let the staff know I'm there. I'm there, but I don't kind of check in with the unit clerks and all that kind of stuff, because I don't want any interruptions when I first start. Like, as soon as the pager's on and you've checked into the system and they know you're there, the interruptions are incessant. And it just lets me get rolling with the first 2 or 3 patients without the hive of wasps stinging you from every angle. And it just lets me get going without distraction. And I've done that for years and years, and I'll keep doing it.
Yeah, I find the occasional time where I arrive late at work for whatever reason, traffic or whatever it is, it's a bad way to start a shift.
Yeah.
Just trying to catch up.
Totally agreed.
And you just can't get your mind in there. And Dr. Weingart, any tips for clearing your mind just before you start work?
Yeah, absolutely. So I'll mirror the get there early, and it's going to keep your mindset in the proper space. But then it also, we just hate people who get there late. They're basically the scumbags of emergency medicine. And that scorn that people feel, it's going to be registered subconsciously. So it's just worth it. Just get there 10 minutes early. And then if I'm on a resus shift, which I always am, I like the ritual of using that time to just check over my room and check in with the head nurse, not because I think that stuff's not going to be there. We've got a system intact now that, it's stocked well, but that ritual of making sure everything is in its place kind of puts me in the mindset and gets me ready to perform at the level I want to. The second thing is to leave your crap at the door. If you had a fight with your partner, if you had interaction with your kid's school, you got to find a way to leave that aside until the shift is over. Because I've tried to do that, double management. Oh, I'll just take a 2-minute phone call and deal with this stuff, frustration, taxes, what have you. Oh, it's okay. I'll talk to my accountant for a minute during, a time I'm grabbing a drink. It just totally takes you out of the mode. You need to just have those 8 or 12 hours be completely reserved and mind free of anything except emergency medicine. And then the last piece, and this mirrors some of the stuff you were talking about from the podcast you did with Rob, is you have to start playing the game as if you're an athlete. You have to sleep well, you have to eat well, you have to exercise. We are in a high intensity field, both cognitively and physically. And I don't think people take it as seriously as they really need to perform optimally.
Beautiful. I love that trifecta of stuff. And Dr. Strayer, anything to add there? I think we've talked about this before, and you mentioned that you don't do any discrete preparation before you arrive at your shift, but anything to add there?
Yeah, I don't have a preparation ritual like many do. I just don't seem to need it, but it's probably, I think, because I work mostly 8-hour shifts and not 12s. And I just find that my mindset before a 12-hour shift is just totally different than an 8-hour shift. And I would advocate, if you have any control over this, if you're working in a busy department, then try not to work 12-hour shifts because I just don't think that most human beings can maintain the level of focus that's required to perform for 12 hours. I know with certainty that I'm not treating my patient up to my standards in hours 11 and 12, and probably not even hour 10 compared to the beginning of the shift. So I think that's an important point to make as emergency medicine is more and more affected by private equity owned staffing companies, at least in the United States. And everyone's trying to squeeze more out of every doc. 8-hour shifts are really a different game than a 12-hour shift. I'm a big fan of invisible simulation in between shifts. So that's how I manage fear of a difficult procedure or a halo procedure, as it were. Invisible simulation is just going through the events of a procedure in your mind. I myself find that the shower is an excellent place to do this. There's something about taking a shower that just lends itself to thinking about how to perform the steps of a cricothyrotomy. And when you do that intermittently, when it comes up, you do fall back to that invisible sim, which is not as good as a real sim or the real thing, but I think it's pretty good preparation. I go through a start of shift checklist, especially if I'm working a resus shift. And both Mike and Scott alluded to this. I also want to make a plug for showing up early. I have to know about all of my references. I find that this is the most critical aspect of, especially in resus, our references are mostly apps on our phone. So know the apps that you're going to use. If you're working a peds resus shift, for example, and you don't work peds very often, you have to have a working knowledge of the app that you're going to use to figure out your endotracheal tube size, because you don't want to be thinking about that when the patient rolls in. So for me, the usual state of readiness has to do with acquainting yourself with your references, the apps on your phones, and then, of course, the critical components of your resus bay. I have a start of shift checklist that is divided up into materials, procedures, and strategies, which I use both for myself as a checklist and as a teaching tool when I'm working with residents. And it really sort of lays out the groundwork for the usual state of readiness.
Excellent. Yeah, you touched on the topic of decision fatigue, which we'll talk about a little bit later, but I couldn't agree more that a shift more than 8 hours is probably not a good idea. In Canada, most of the nurses' shifts, or at least in Ontario, are 12 hours, and you see them just do a dive bomb after about 8. I personally find that after about 6 hours, I can't really think.
Our group's moved completely to 7-hour shifts now. It's way better.
Yeah.
Every hour you take off is better. Yeah, it's hugely better.
Especially overnight.
We've just had some really interesting thoughts on what to do just before the shift and as you arrive. And I think the thing that is coming out that the three of you all do is you really have this ritual of having, Mike's got his computers and his desk, and Ruben's got his checklists, and Scott is, checking the room. So they all, in one way or another, have a routine of doing a check on things, which I guess just prepares your mind for what's next to come. So that's about before the shift and right at the beginning of your shift. Now let's move on to how to maintain a sharp and agile mind during your shift. And I want to start this part of the conversation with interruptions. Now, we get interrupted literally hundreds of times a shift by calls, by our beloved colleagues, by our patients' families, to read an ECG, an overhead call about a patient needing analgesia, a tap on the shoulder to reassess the guy in bed 16, etc. And interruptions, we know, are detrimental to how we think on shift. Because when people are interrupted, they can take up to 50% longer to complete a task. And even more concerning, they can make up to 50% more mistakes, or slips, as they call them in the performance psychology literature. So, Dr. Weingart, let's start with you. How do you minimize interruptions, and how do you deal with them when you do get interrupted?
Wow. This is a topic. We've been teaching an anti-burnout course for the past 2 years now. And we devote an entire session on this because this, when we did the surveys, was a major source of discontent for so many emergency docs. They just can't think straight because every second they're getting interrupted. So I definitely have some pretty clear vision of what works and what doesn't at this point, having gone through a few cohorts of this. The first one is a mindset change, because most EM docs, not myself, but most EM docs are nice. And as a result, they don't want to be the person who brushes off interruptions. They want to be there for their colleagues. They want to be there for their nursing team. And I love that. But since we know it's a patient safety issue to get interrupted, you make more mistakes, you make errors, you have to change the mindset. And the way we have people change the mindset is instead of saying, wow, if I'm not accepting these interruptions, I'm not a nice person. Instead, for the safety of my patients, I can't allow myself to get interrupted. And that mindset shift, that's a paradigm changing vision of saying, like, it's just not safe. I have to block these people from interrupting as much as they are, not because I'm mean, but because my patients deserve the best possible care. And then the next piece of that is the people who do the interruptions will always find the doc easiest to interrupt. So whoever is the nicest amongst the cohort on the floor is the one they will vacillate towards asking. And so you kind of don't want to be the real, there you go, Anton's pointing to himself. You don't want to be the person who's furthest on the niceness spectrum. So you kind of got to, be in the same as everyone else in terms of that. Otherwise, you'll see these docs and they're the ones who have these bright smiles on their face as they walk in the door, and they will look at every EKG. They will listen to any, problem. They will pick up any phone call for a transfer, and they're just getting destroyed. And then, they keep smiling, and then they come to us and say, we're thinking of quitting emergency medicine. So you can't do that long term. So you have to not be the easiest of the docs. The next one is finish whatever you're doing before the interruption, which means if you're charting, if you're putting in orders, just turn to the side and say, oh, I'm so sorry, I'll be with you in 1 second, and then finish what you're doing. Otherwise, you do get these slips, you get these task interruptions, and then you lose it. And then, serious things can happen. Next one up is ECGs, a big source of interruptions. Pretty much an unnecessary source of interruptions. And I think something that'll disappear probably in the next couple of years as these new AI/learning models really have shown better quality than emergency docs at this stage of the game. But, soon. But until then, I've just told everyone, and they just know this by now, I don't have to repeat it. If it says STEMI on the EKG, then just interrupt whatever I'm doing. Otherwise, I have a pile right in front of me, and everyone knows you just leave it in the pile. And it takes a while. The techs are like, well, I have to wait here for him to sign. And I'm like, no, you don't. And they're like, yes, I do. And then I had to go to the administration and say, do they need to stand here? And they're like, no. So they just put it in the pile. And as soon as I finish what I'm doing, I look at the EKG. No one has died from 30 seconds wait on the EKG. But instead of someone hanging over my shoulder with a piece of paper, that just ruins my entire flow, I'll just look at it from the pile. And if I'm not at my desk, they put it in the pile. And now I know there's EKGs to look at next time I swing by. The penultimate one, Post-it notes, game changer. Put Post-it notes next to your station and say, if you have something that you need that isn't emergent, it's not a sick patient, because I always want to be interrupted for anything with sick patients, but it's not emergent. Take a Post-it, put it on my screen, and I will get there, and I will take care of it. And by that same token, the last one is, if your charting system, if your EDR has this capability of communication through a spot on the patient flow board, that lets nurses leave notes to docs, docs leave notes to nurses that don't go into the medical record, that don't get seen by patients on the big tracking board screens, then just have that be your default for communication for non-sick stuff. Just say, patient in bed 6 needs a Tylenol order. That shouldn't have to be an interruption. That should go on the board. And then when you scan through, you see that, you put the Tylenol order in. All right, those are the initial tips I have. I'm sure my brilliant colleagues.
Yeah, wow. I just want to review there because those were brilliant. So number one, it's the mindset of safety of the patient first. Number two, it's finish what you're doing before you allow yourself to get interrupted. Number three is the pile of ECGs. I love that idea. And then the Post-it notes, that's just a brilliant, simple idea that I've never thought of myself, I have to admit. Write it down either electronically or on an actual piece of paper, rather than interrupt you. Love it. Dr. Strayer, how do you think about managing interruptions, minimizing them?
Yeah, a couple of comments on Scott's suggestions without making any references to Scott's reputation. Remember that you also rely on your staff to interrupt you when there's something important happening. And if you have the reputation of being the person who scowls at the tech, I'm not saying that's you, Scott, but if you have the reputation that has the person that scowls at the tech, that tech will not feel empowered to approach you. And since it's not really in their job description to do that, I mean, maybe the nurse is supposed to approach you when they're concerned about a patient. Technicians often really aren't, that's not really in their purview, but you sure want them to feel empowered to approach you. So there's some right middle ground there. And I think, Scott, that's exactly what you were saying, is that there's some right middle ground in terms of approachability.
Yeah, Dr. Strayer, I think you're right there. I think it really has everything to do with how you communicate. I think you can be as aggressively anti-interruption as Dr. Weingart is describing, and at the same time be a quote unquote nice or kind doctor. I think it's how you actually communicate, both verbally and with your body language.
Yeah, there's some right way. I don't think I've mastered it yet, but there's some right way to be kind to people while at the same time saying to them, usually with body language or facial expressions, I'm a kind person and I want you to feel empowered to approach me, but understand that every time that someone approaches me, patient care suffers.
It's a good point.
The points around asynchronous communication are really huge. That's the Post-it note is a form of asynchronous communication. The EMRs all have various ways to do that. Epic now famously has Epic Chat. I don't know if any of you guys have had the pleasure of Epic Chat. So it's a texting platform that's within the EMR and it's linked to individual patients. It's extremely powerful. It's a little bit too powerful sometimes. It gives people very easy access to your inbox, but when it's used appropriately, it really makes a huge difference. Instead of the nurse having to walk up, stand there, wait for you to finish what you're doing, say, "Can you please order morphine?" Yeah, the Post-it is a great idea if you can read what they're writing on the Post-it or the communications box on the tracking board. But a text message in the EMR also works quite well. A couple of additional points I would add is to remember that multitasking is a myth. We're all taught at some point that, emergency physicians are the masters of multitasking. There is no such thing. You cannot do two things that require a high level of attention at the same time. And if we're being utilized properly, almost everything we do as an emergency physician should require a high level of attention. So being an expert emergentologist means not doing more than one thing at a time. It means knowing how to do many important things in series. And for me, where I turn the corner on this is recognizing that I cannot rely on my memory to be my task list. If someone says, "Can you please order morphine for this patient?" and I say, yes, I will do that. There are three options: do, delegate, document. Either you do it right now, you delegate it to someone else, or you make a reminder for yourself. And once you sort of establish that rule for yourself, you will find that you become much more effective at doing multiple things in series, which is what multitasking really is.
I love that. The interruptions heuristic. Never rely on your memory, do, delegate, or document. Great. Dr. Bessner, anything to add in terms of interruptions?
I completely agree with my colleagues on every point, to be honest. My main management principle forever has been touch everything once as much as you possibly can. I have Post-its on the back of my laptop that I hand to people. I've done that for a long time too. And that's where my lists come from that, Ruben's talking about, of things that I have to do. I'll have a Post-it for each one of those so I don't forget, because you absolutely will forget. And when you're on a phone call and the nurse is talking in this ear and that ear, I've got multiple Post-its going at any given time. And you can't type fast enough, I find, to make that work. So, regular sticky notes are great. When it comes to the Epic chat function, that's been really great in some ways and really terrible in other ways. And anybody that's bringing that into their system, I think, needs to be careful with that. One of the things we've had to really do with the nurses is to try to get them to stop thanking us. Like, they ask for something, you do it, and then they thank you. And every time that happens, the bubble pops up, right? You know what the hell's in the bubble. It's just a bubble. And you got to interrupt what you're doing to look at the bubble and come out of everything you're doing. Like, it's driving us all bonkers. So we're actually having a whole session with our nurses almost daily going, please stop with the niceties. Just don't do it. And it's so counterintuitive, right? You want to be polite. You want to be nice. You want to be collegial. But that kind of stuff is driving us all crazy in that program.
The technical fix for that is an emoji. So there's a thank you emoji that you can configure to not alert you as a new message. So it's just an emoji. So the thank you emoji is, this emoji and the hands clasped together. And if you just say when you want to acknowledge something, just thumbs up. When you want to say thank you, hands clasped together. That way you can sort of maintain, because there's no way you're going to be able to get Canadians to not be polite. It's
difficult. It's tough. Yeah. I did not know that. That's great. I'm going to take that to our IT folks.
Yeah, We're getting real granular now. There's so much gold in there. All right, I want to move on to cognitive load. So, closely related to interruptions on shift is the massive cognitive load that we accumulate on shift. Some of us have become masters of balancing multiple tasks and continuously reassessing and reshuffling what's most important without overloading our neuronal circuits. I sometimes feel that I'm cognitively overloaded with too many tasks at hand, and then I feel that I can barely think at all. And sometimes my decision fatigue sets in, like I was saying before, usually around 6 hours or so. That's the mark that I usually start to get that decision fatigue. And especially if it's like 4 a.m. when that 6-hour mark ends up happening. And it's very frustrating, I find. We'll talk specifically about cognitive overload in the resus patient a bit later in the podcast, but I just want to talk in general now. Dr. Betzner, how do you avoid cognitive overload to the point that you just can't think straight? In other words, how do you mitigate the detrimental effects of high decision density and decision fatigue that, are just so abundant in the ED?
Well, I think we just touched on it in many ways. Again, touch everything once, deal with it, get it off your plate, move on. So you're not cognitively overloaded. That's the biggest one, honestly. You just have to be sequential. And you can't be parallel. You can't be doing multiple things at the same time. You just can't, effectively at least. And so, yeah, I'm a stickler. I see one patient at a time. I take care of everything about that one patient at a time, and then move on to the next patient as much as I possibly can. Now, there are times, I was in the resus bay 3 days ago, where I had 3 patients arrive within 5 minutes. But in that circumstance, you're sitting in a small room with very sick people all around you, and you can still sequentially move patient, dealing with the priority for each patient as it comes up. But I still was only doing one thing with one patient at a time, moving to the next patient, taking care of the priority for that patient, moving to the next patient, taking care of the priority for the next patient. So I'm just big on completing tasks one time as much as I can. And then I don't feel overloaded. I just don't. I don't find that I'm stressed out because there's too much stuff going on. That doesn't happen.
Great. And Dr. Strayer, in terms of cognitive overload?
Yeah, that's really interesting, Mike, that you make a point of only seeing one patient at a time, because I've been doing that for my entire career, and I am the only physician I know that does that.
Oh, I definitely do that. Yeah.
There are 2 types of patients really in emergency medicine. They're the patients who need resuscitation and the patients who don't. The patients who need resuscitation should be in the resuscitation bay, of course, and that's an entirely separate cognitive paradigm, because your cognitive workflow is determined not by your priorities, but by the resuscitation priorities of the patients that are in your resus bay. For most of us, it's a minority of patients, and most of our emergency practice is patients who don't need to be resuscitated. And so they are by definition stable, and you can control how you approach them. It is ubiquitous in every department I've ever worked for physicians, especially residents, to pick up 3, 4, 5. I've seen residents pick up 5 patients at a time, meaning they will assign themselves to 5 patients, go see 5 patients, and then return to their workstation and try to document and put in orders on 5 patients. And I love, Mike, that you are as stringently opposed to that as I am.
It's a terrible idea. I will not do that or allow my residents to do that. Yeah.
Yeah. So there's a variety of reasons why that's a terrible idea. But just from the purpose of cognitive unloading, seeing one patient at a time, and certainly in doing it in a very structured way, and I'm extremely structured in my approach, really keeps your cognitive load to a minimum, and more importantly, focuses all of your energies on one patient at a time, so you can front load all of your cognitive energies at the time of the patient assessment. And I have a whole cohort of ways that I do that. One I'll mention here is at the start of the patient encounter, when you're doing after you've done your patient assessment, you come back to your workstation, you're formulating your plan, you're putting in your orders. That is the time to come up with your plan for negatives. Positive results dictate care. We know what to do with positives. If the CT scan shows appendicitis, we know what to do with that. The cognitive load comes when the CT scan is normal. Now what do you do? And the time to make that decision is not 6 hours from now when the CT scan has been resulted and you don't even remember who that patient is because you've seen 17 patients in between then and now. The time to decide what to do with negative results is at the time of the initial assessment. Plan for negatives at the outset of care. And the last thing I'll say on this cognitive overload point has to do with when there are more patients to be seen than can be seen. And this happens with increasing frequency in many departments. I know in Canadian departments, this has reached epidemic proportions. And it is critical for every emergency physician to understand that when there are more patients to be seen than can be seen, that is not your problem. That is a systems problem. And so when that happens, you have to fall back on what you know to be the priorities. Priorities 1, 2, and 3 are resuscitation, identification of dangerous conditions, and symptom control. There are a variety of other responsibilities, but it's 1, 2, 3 in that order. Everything else can wait, regardless of what your MBA hospital exec says.
Well put. Yeah, that is becoming a problem, especially in Canadian EDs for everyone. You can just see it unfolding when there's a really busy shift. You just see everyone's stress level going up. You see people not performing at their best. And then a week or two later, you hear about the misses and the bad outcomes. So I think that's such an important point, having to prioritize and also thinking of, you need to do what you are responsible for at that moment, and you can't control the system problems at that moment in time. And so you need to just prioritize the resus patients, making diagnoses of life-threatening problems and treating symptoms. Dr. Weingart, this is a huge topic in itself, the cognitive load, but what would be your top points in terms of managing cognitive load?
Yeah, it's so funny. I didn't think there'd be such agreement amongst the three of us as guests, but one of the things we teach adamantly is one patient at a time flow. So all three of us are in agreement on this. And I'll mirror most of what Ruben says in slightly different terms. What we teach is to figure out your maximum safe capacity. And, that'll get better as you can go through your career. You get more experience, you get more skill. But let's say whatever that is for you, 100% of that is not where you should be performing during a shift. And where you want to be is somewhere between 85 or 90% of your maximum safe capacity for most of your shift, unless there's multiple resus patients, like Mike said. And then you up gear to take care of those patients, no matter how much you have to stress yourself. You might even be beyond your maximum safe capacity. You might not want to be performing at that level. You have to, because there's resus patients. And if you can't get other people in there to help, then you got to do what you got to do. For everyone else, I don't care if there's 100 patients in the waiting room or no patients in the waiting room. You perform at that same gearing, at that 85 to 90% maximum safe capacity. You don't want to be lazy. You don't want to be looking at Twitter. But by the same token, you don't want to get more anxious and start running around like a chicken with its head cut off because there's a lot of patients to be seen, because it's a patient safety issue. So whether there's tons of patients to be seen or not, you find your capacity that will get the job done with maximal safety, and then you stick with that the entire shift. The documentation point that Ruben mentioned is so critical. Now, he mentioned it from the perspective of figuring out what to do when negatives come back. But the other thing is to start asking yourself, well, I have the thing that's primarily on my mind as what's going on with this patient. And then you need to think about all the other things it could be that are life threats. And the time to do that is during your documentation, because that's when you're going to have the maximal capability of really thinking through everything. Because as you write it or type it or dictate it, it's going to feed back to you. Oh, crap, that sounds ridiculous that I'm sending home this 85-year-old with chest pain. What the hell am I thinking? I probably need to get a snack. My brain's not working well. When you see it there in the chart, it's going to start making sense and things will be cute. Now, I have a lot of colleagues who are doing their documentation at home the next day. They are missing out on an incredibly valuable possibility of preventing patient error. And then they're also making their life worse. So that's the stuff from the things that have already been mentioned. But then I'll mention one more, and it's the concept of thinking less. And now this seems counterintuitive. Oh no, we want to think more. There's too much stuff in the course of a shift for you to be thinking through each and everything as if it's a de novo problem. What you need to do is take every possible advantage to make things happen through heuristics, through pre-planned actions, so that when there is a difficult decision, should I send this patient home or not? It's kind of a borderline case. Then you have the cognitive capacity to do that, which means You want to have heuristics that are functional, that have been tested, that work. You want to have personalized flows. You shouldn't be having to figure out for each pulmonary embolism workup, well, okay, is this a D-dimer case and not a D-dimer case? Should I do a perk? What was the perk? I don't remember the criteria. Let me go look that up. That's a ridiculous source of excess cognitive load. You should have personalized flow charts for every common presentation to the ED, such that you pull up, oh, here's my personalized workflow for PE. I've updated it on the most current evidence. I know exactly what I'm going to do for each of the risk stratifications. Oh, here's the PERC criteria already in front of me because I have it on my flow chart. And then when I get a PE workup, it's no brain power at all, and the cognitive load is reserved. Now, if you want to do that, then you need a place to retrieve it. Ruben has a website. I have my own, personalized knowledge management system. You could be in a notebook. I don't care, but it can't be at home because that's not going to help you. So you need to be able to immediately access the common ways you handle most of the things that come into the ED. And now all of a sudden your cognitive load decreases dramatically. And then the last piece, and Ruben's such an exemplar of this, is you should have easy access to instructions for how to do all of the complex bureaucratic or administrative tasks that go on in your department. So I need to transfer someone to the PEDS center. Oh, well, that's going to be 30 minutes of talking to various people if you don't have, here are the 7 steps to transfer someone to a pediatric center. And you shouldn't have to be asking the charge nurse. You shouldn't have to be asking your colleagues. You've done it once. You wrote it down. It's now there in that same easily accessible personal knowledge management system. You go to it. All the phone numbers are there. And now it's less cognitive load. Now, in an ideal department, it's done at a departmental level for each one of those. And that's what Ruben built at most of the centers he's at. But you could build it for yourself if your department hasn't had the foresight to do that for all of their constituents.
So just to review there, actually, so it's thinking less with pre-planned actions and heuristics and such. Of course, plan for negatives before you get the test results. And we'll talk a little bit about test result interpretation a bit later. And then figuring out your maximum safe capacity and then working at about 85 or 90% of that, I think is also a great tip.
Do you dread doing your clinical notes every shift? Do you feel like you can never get ahead of charting? If you're shaking your head yes, keep listening. Freed is an AI scribe that listens, transcribes, and writes medical documentation for you. Notes are written in your style and ready the moment the patient encounter is over. Just imagine leaving work at the same time as your last patient. Freed is HIPAA compliant, secure, and takes less than 30 seconds to learn. Artificial intelligence can't replace you, but it can do the administrative work that no human should be subjected to. All the magic happens in just a few clicks so that you can spend less energy on charting and more time on doing what you do best. Freed learns your style over time, just like a human scribe, and it'll never quit on you. More than 6,000 of your clinician colleagues already use Freed AI. Get back to spending your clinical time caring for patients and let Freed AI do the rest. Head over to getfreed.ai and use the code EMC50 to receive $50 off your first month with Freed. That's getfreed.ai with the code EMC50.
Closely related to managing cognitive load is managing flow. I'm not sure there'll be much to add here, but let's explore. I find that if I'm managing flow really well, my mind feels sharper and they kind of feed off each other, managing flow well and then having a decreased cognitive load. And maybe if you're contributing to a better ED flow, you experience less stress. And so you have less cognitive load and less catecholamine overload, which helps you think better. Dr. Betzner, I've heard from some of your colleagues that you're not only a clinical ninja, but that you manage flow better than most docs out there. Can you tell us a little bit about how you manage flow in the ED, which I think can then really have a secondary advantage of thinking more clearly and dealing with cognitive load?
First of all, I do think about the negatives just like you do, Ruben. And I make my decision about disposition immediately after seeing every patient. Maybe there's a 10% cohort where you're not quite sure where this one's staying or going yet. But the vast majority of people, I've made my decision after seeing them, whether they're coming or going, irrespective of test results, which helps. And we actually keep stats on our consults and what percentage of our consults get admitted, which I think is, if you're not doing that as a group, you should look at that. My personal stat is if I consult you for admission, you admit 99% of the time, has been for a long time. So, I think it's important to look at that. It's important to look at what your own numbers are and see where you're compared to your colleagues, because if your consult to admission rate's 60%, you're not doing something right. You're not thinking right, and there's something that you need to adjust in your practice. Getting back to the question in terms of flow, starting early helps, like I talked about, getting rolling early and getting through a few patients and sort of building up some numbers early in the shift. I kind of go hard and then I glide at the end in the last hour or so, and can get through a lot of patients as I'm wrapping things up. But I do a lot of what Scott was talking about too, that writing down and thinking and making your decisions as you write, and making sure that, everything is tidy and neat and done. Like, I never document when I get home at all, ever. It's done. Like, when my shift's over, I'm done within minutes. So all of that is tidy, and I keep on top of flow because the decisions are quick and final. Like, I'm not waffling about things. I don't know how else to talk about that. I don't know that you can teach that necessarily. You have to kind of see a lot of patients and get confident in your decisions before you get there, I think.
Well, you can teach that documentation is part of the patient encounter.
True. Documentation you teach. I'm talking about overall decision making and being final in your decisions and being comfortable with your decisions, having finality, and not like, I don't go home and think about patients.
Yeah, I find it interesting how much uniformity there is on the 2 points so far that I think are wildly discrepant among emergency physicians. The first is seeing one patient at a time, which I think is the exception rather than the rule. And the four of us seem to hew to that rule quite assiduously. And the second is the notion that documentation is part of the patient encounter. So the patient encounter is not over until you've put in your note. That's part of the patient encounter. And you don't see a bunch of patients and then document later. You don't wait till the end of your shift, or God help you to when you got home. And I still see so many of my colleagues doing that to their own detriment and clearly to the detriment of patient care. Not to mention the very strange way you have to document when you document after the fact. It's like you have to document in this like time travel style where you're like, if the CBC is so forth and so on. Meanwhile, the CBC was resulted 7 hours ago because that's when you were seeing the patient. And all this makes no sense from a documentation perspective. And this is routine in most departments where I work. And it's just interesting that there seems to be so much uniformity among the four of us that this is bad practice.
It's a trick the system's playing on us. And you talked about the corporatization of EM, and that's part of it. But even at places where that's not, the trick is still being played, where the rewards, whether explicit or implicit, are there for the docs that are making maximum RVUs, that are moving as quickly as possible. And that factors into, how could I be more quick? And then that person pulls away from the pack, and then that is the new standard by which the rest of the pack is evaluated. So there's this natural inclination to trying to cut corners as much as possible. But documentation is a false corner to cut. We've actually found better efficiency if we teach people to document well. And Ruben's spoken about in the past, 3 minutes per patient for documentation. And we're at that same place for the students that I teach on this. It doesn't have to take a long time. And it's actually a false efficiency for all the reasons that Mike and I mentioned. You're losing out on one of the most valuable pieces of the encounter in terms of reflection. So there's other ways to become more efficient. And, maybe we talk about those in another podcast. But documentation at home is not the one.
Totally agree. We've covered so much great stuff already. I want to talk about managing negative emotions and frustrations on shift. Now, there are plenty of points during an emergency department shift where emotions are high and others where frustrations come over us, or maybe both at the same time even. Some of these frustrations are within our control and some of them are not. I'm sure our listeners can think back to their last shift and remember many frustrations off the top of their heads as we speak. And we know that negative emotions interfere with thinking and performance. Sometimes when I'm really angry or upset, I find myself switching from that cool and calm and collected Dr. Hellman into grumpy, preoccupied, can't think straight Dr. Hellman. And there's all kinds of self-regulatory strategies that we can use. One I came across that's been extensively studied is implementation intentions. And there are these little plans for obstacles before they occur by filling in the statement, when X, then Y, with positive statements. So for example, when I can't get my sick patient up to the ICU in a timely manner, then I'll continue to take excellent care of the patient in the ED until the bed is available, saying that to yourself rather than, why the F isn't this patient in the ICU yet? I'm going to complain to my ED chief. And if you write up and tell yourself implementation intentions for the most common frustrations that you regularly face in the ED, you'll then be better equipped to handle them, and you'll stay cool, calm, and collected, and you'll be able to think better and perform better. Dr. Weingart, what's your strategy for dealing with high negative emotions in the midst of your work?
Sure. So when we teach on this one, the first thing we ask them is, are your negative emotions the result of physical things? That's the key. And most people forget this, is most people in the ED experiencing negative emotions are actually incredibly thirsty or hungry. So we really advocate regular eating, drinking, toileting, and occasionally going to see nature in the course of your shift, for all of the reasons why Las Vegas is so detrimental. Being underneath those fluorescent lights for 8 hours is just crazy. If you're taking a phone call, go outside to do it. So once we've taken those off of the table, then we can actually start talking things really from an emotional lens rather than from just severe dehydration causing you to be grumpy, which is the major source of my grumpiness in ED. I find if I'm grumpy, it's generally not what's going on around me. It's that I've just been banned from drinking water at my workstation for whatever idiotic implementation of a misreading of our OSHA guidelines. So once those are gone, then we start dealing with the true emotions. The first one is, and we have such a basis in stoicism in the way we teach on this, is agency. And a lot of the things people get negative emotions on in the ED are things completely out of their control, and therefore these emotions are wasted. So if you can't fix it, then it's not a problem. It's the playing field. So by which I mean, if you come into a shift and there's 20 holds, you could get upset about that. It's not going to do anything. So you just say, all right, well, today I'm only going to be working with the 3 beds that are still available, and maybe I'll be seeing a bunch of the patients in the waiting room. All right, let's see how I can make that the most efficient way possible for that milieu. Okay, I'm going to make that a challenge now. All of a sudden, the negative emotions aren't there. If you can't change it, then don't worry about it. If a patient comes in seeking drugs, yeah, you could give them the drugs or not, depending on the unique circumstances of that patient. You can figure out a way to deal with it in a compassionate manner. But what you can't do is get angry about it if you think it's going to make any difference. It's just going to make you miserable. And I see some of my colleagues who, a patient comes in and they're seeking opioids, and they, for the next 2 hours, will do nothing except rant about how broken the system is. They're making themselves miserable. I'm sure their encounter for that poor patient was not very well done either because of that attitude. So you have to get rid of it. And it's working with your own brain to say, if I can't change it, I'm not going to care about it. And now some things you can change, some things it's worth making us think about, especially if it's affecting patient care. But for most of it, it's not. These negative emotions go nowhere. They're just spinning around wheels. And then the last one on that same note is stop being tricked into negative emotions. If a patient is nasty to you, you could take that on board and have that ruin your shift. Or you could realize, wow, I'm lucky. I'm going home to my really nice house in my beautiful car, and I'm making I have a job that's pretty much recession proof. And this person's life probably sucks right now. And it's probably a lot worse because they had to spend 4 hours in the ED. I should just be happy I'm not in their shoes right now. And all of a sudden, you're going to have a marked change in your attitude, a marked change in how that patient's interaction affected you. Same thing with difficult consultants and potentially even colleagues. You could have the belief that this person's the worst person in the world. They're just an asshole. Or, hey, maybe they're having a really bad day. Maybe their life kind of sucks at home. Maybe they've been on shift for 90 hours if it's a surgeon. And just say, all right, I'm going to give them the benefit of the doubt, not for them, but for you, because you will feel better in that shift if you start playing these mental conversations with yourself in a way that leads to positive emotion rather than negative.
Couldn't agree with you more. Dr. Betzner, any tips on managing high emotions and frustrations?
Most of the high emotion, frustration kind of patients that used to bother me when, 25, 30 years ago when I was a young doc, that I don't, and like, there isn't a patient on the planet that gets me cranky anymore at all. Part of the reason is they're all there for something. And, if we treat people well and we're nice to them, you sit down, talk to them, even the most manipulative people generally come around and can have something positive come out of these visits. So I make it a bit of a game to try and turn these negative, difficult patients into somebody that's actually thanking you at the end of the visit, even though you didn't give them anything they wanted. The thing about colleagues, I mean, our colleagues are cranky these days. Everyone's working harder than they want to. They all have waiting lists that are ridiculous. But if you acknowledge that up front in your conversations, when you hear tone on the phone, that's negative right from the minute you start having the conversation. But actually acknowledge it and check in with people, see how they're doing. Most of them come around too, right? So just being a decent human being helps a lot and will make you feel better afterwards in every way, I think. A sense of professionalism is really important to me personally. I don't get mad at people. I don't yell. I don't raise my voice. I don't do any of that stuff because it doesn't get you anywhere, and it'll eat you up inside. And I still find the vast majority of my shifts very entertaining after 30 plus years of doing this because I have that attitude. I think you can make things better for people, including your colleagues, even the really difficult ones.
Great. And Dr. Strayer, any other tips about handling high negative emotions or frustrations?
Couple thoughts. Lots been said in recent years about mindfulness and meditation. I'm no guru, but I do have a mild meditation practice. And the major benefit I've taken from that practice is that I recognize when my own internal milieus become disturbed in ways that I didn't before. And I'll also echo what Scott and Mike just said about patients versus colleagues. After 20 years, I am no longer emotionally charged by patients just because the power differentials, it's so awful to be a patient in the emergency department. I mean, it's as simple as that. And so it doesn't take long to recognize that it's not about you. It's about what's going on with them. As angry as they are seeming, it's because of what's happening to them. It really has very little to do with you, even if it's being framed as something that has everything to do with you. Recognizing your own emotional valence when you're not getting the answer you want from a consultant takes practice. It's a mindfulness practice. But once you recognize that your own blood pressure is going up, then that's the first step to taking steps to mitigate that rise in blood pressure. And most of the time, all it takes for me, and I think for most people, is once you start to sense that your own blood pressure is going up because your consultant is alluding to your ignorance, is you think, oh, wow, my blood pressure is going up. Let's take a couple of deep breaths. And you take a couple of deep breaths and you feel your blood pressure come down. And suddenly your interaction with that consultant is a totally different flavor. The other point to make has to do with another type of emotion, another type of negative emotion, which is anxiety. And there's a lot of anxious emergency docs out there when they're dealing with crashing patients and difficult consultants. And anxiety comes from uncertainty. And so the way I think this can be best managed is to come up with a plan for whatever the outcome, the various outcomes can be. So for example, if you are very nervous about this patient in resus bay number 3 who's got no blood pressure, and you think, I think this is the problem, and I'm going to do this. You still feel this lingering anxiety, and it can be really distracting when you're trying to see other patients. You're going to implement a couple of measures to try to address the blood pressure, but you can't focus on the next patient you're seeing because you're still thinking about that patient in bed number 3, and that's very distracting because you're anxious. The way to manage that anxiety is to add certainty by coming up with a plan for what could happen. So you implemented a few things. There's really only one of two things that's going to happen after you put in your orders. The patient's going to get better or they won't. And if you have a plan for what to do, if the patient doesn't get better, your anxiety level will come down. It's similar to planning for negatives at the outset of care. When you're dealing with resus patients, plan for different ways that the patient doesn't improve or gets worse. And by going through that mental exercise, you address what underlies anxiety and you mitigate the anxiety that can really interfere with your ability to perform well on shift.
A word from our sponsor, Metricaid, the experts on scheduling systems. Since 2015, I've been using Metricaid, the incredible self-scheduling system that has made my life and the lives of my colleagues so much easier. Metricaid can really help minimize the drawbacks of shift work we all know so well by not only ensuring equitable distribution of shifts, but also integrating circadian rhythm-friendly recovery time into their algorithms. They minimize my sleep deprivation, which allows me to be a better EM doc on shift. I can take better care of my patients and still have energy left after my shifts to enjoy other aspects of my life. Check out metricaid.com/emcases for more details on how this awesome scheduling system works.
I want to move on now to the resuscitation situation, sort of the mindset of the resuscitationist. So far on the podcast, we've talked about pre-shift prep, managing interruptions, cognitive load, managing flow, dealing with the negative emotions and frustrations. Let's talk about resuscitation. So before we get into what we do during the resuscitation, we have to talk about how to set yourself up when you get that call that there is a sick patient coming in or there's a cardiac arrest coming in or what have you. Dr. Weingart, you have a special interest in this. Maybe you even invented the subject of the mind of the resuscitationist. And this is something you're obviously passionate about. We've talked before on EM Cases about Beat the Stress Fool a few years back, and I'm sure you have some updates for us. Again, this could be 3 whole podcasts on its own, but if you could just give us some of your tips and tricks on prepping for the resuscitation, maybe elaborating on your Beat the Stress Fool paradigm.
Yeah, sure. So, preparing for the resuscitation, generally in a functional system, should be minimal in terms of room prep. So what you want is a resus-ready room, meaning you don't have to open up and set up suctions. You don't have to set up your intubation equipment. You don't have to get the room ready for a cardiac arrest. Everything should be there already. And you could start cutting down on the steps by having a good system. Now, some places don't have that, and then you're going to have to do a lot of prep. Like if you hear a patient's coming in being bagged and you have to rip open, 20 packages and get set up, and then you got to do it if your system won't actually have that as their standard. But it would be much better if they did. So having a resus-ready room cuts down and then gives you the time instead to mentally prep yourself and your team. So you wanted to talk about Beat the Stressful. Beat the Stressful was a just-in-time stress reduction tool invented by my buddy Mike Loria and myself. And it's just to bring down the anxiety that Ruben was talking about earlier. And the 4 components of the original were breathe, talk, see, and focus. Breathe is to do tactical breathing to actually lower your sympathetic tone if you start getting that anxiety and you start getting all of the negative effects of stress-related sympathetic tone. So, we originally taught box breathing, 4 in, hold for 4, 4 out, hold for 4. Now we push more towards vagal breathing, where you just double your exhale time. It's easier to remember, and I think it's at least as effective, if not more so. The self-talk is just positive self-talk. So, I got this. I trained enough to be able to handle this. I've done so many of these already. It's all going to just be fine. I have a great team around me, whatever it takes to counter negative self-talk. Seeing is the mental rehearsal, what Ruben was referring to as the invisible simulation. If you have a patient coming in being bagged, then you could just visualize, all right, here's the 3, attempts I'm going to take. Here's how I would handle putting the LMA in. And then here's how I do a cricothyrotomy. But you actually see yourself doing it. You don't just see yourself doing it. You see yourself doing it successfully. You see yourself doing it so well that, everyone around wants to high-five you afterwards. That's the mental rehearsal that we've had proof in the athletic fields. No one studied in emergency medicine as diligently as I'd like, but it seems to work for everyone we expose to. And then the last one's a focus word, a mantra, if you want to put that horrible term to it. This one you can't develop in real time. You have to develop it outside the shift, and then you use it in real time. So this is a word that you've associated with relaxing activities, flow states. Ruben was mentioning meditation, which I'm obviously a big fan of if you've been listening to the podcast as well. And if you end your meditation sessions or your mountain biking or whatever you do that brings you to a state of relaxation and you start building a word to associate with that, then you could now use that word later on. For me, the word is smooth. And so before I'll start a procedure, I'll just say smooth in my head or out loud if I want to make the people around me amused. And then all of the previous mental states that have been linked to that are now going to come to bear. So that's Beat the Stressful.
Thanks for reviewing that.
Just one comment relates to what Scott just said about smooth. In the helicopter environment, which I spent a lot of time in over many, many years, our pilots had a saying, and I used this for many years, and it's part of my mantra going into these recesses, is slow is smooth and smooth is fast. And the helicopter pilots would say that all the time, slow is smooth is fast. It's totally true.
I want to talk now about prioritizing actions. So prioritizing your actions during a resuscitation. William James famously said, the greatest weapon against stress is our ability to choose one thought over another. And I guess you could say the same thing about one action over another. And we know from Miller's law that the average person can only keep about 7 items in their working memory at a time. How do you go about prioritizing actions in the heat of resuscitation? Dr. Weingart?
Yeah, I could talk through some complex algorithms, and I'm sure Ruben will, so I'm going to leave that off. What I've come to at this stage of the game is just I need to feel in control of the patient's physiology. And when I do, then I have all the time in the world to have, cognitive processing about what's actually going on. And when I realize that that's slipping, then you have to take control. And that might mean controlling the airway. It might mean more aggressive control of blood pressure. It might mean gaining more monitoring. It might be getting additional help. But whatever it takes to feel like I'm in a state of ease, a state of relaxation in the resuscitation, then I know things are going right. And when that stops happening, I know I need to take action. And the actions usually will become pretty apparent. But I feel that many people, especially at the beginning of their careers, don't understand that they should be in a state of ease. That state of heightened tension they think is the proper response to a sick patient. And therefore, they don't take the steps to immediately and aggressively get back to that state of ease. So I think really that mindset shift is the best thing I could say right here, is if you feel out of control, then you need to take steps to fix that. The patient's physiology might be out of control, but your mind should be in a state of relaxation, even in the sickest of patient resuscitations. And the pacing of that, the aggressiveness, is where I think people fall off. So for instance, you could have a patient with their blood pressure in the toilet and let's load them with a liter of fluid and see what happens. All right, let's start norepi at 5 and see what happens. And for the next 30 minutes, if your patient manages to survive, you're going to be in a state of heightened tension. On the other hand, if you aggressively treat that patient in minute 1, you start them on norepi at 25 to temporize, regardless of what their fluid status is, to get their blood pressure up. We'll figure that out later. Or you aggressively push blood, or you take the airway earlier because the patient is out of control and you're not going to wait for them to crash and burn to prove that they need that airway. Then all of a sudden you're back to a state of ease.
My anxiety in resusc cases comes around diagnostic uncertainty. If I know the diagnosis, I generally know what to do. And then it's a matter of just executing on your plan to do that thing. And there are logistical pitfalls that come up. The most obvious is when the patient has poor access. And that comes up frequently. And that's a frequent source of stress until that's resolved. And until that's resolved, I endorse what Scott was just saying. When you find that, for example, your patient has poor access and everyone's struggling to get access and the patient's not doing well, then you need to recognize that as something that needs to be managed with maximally aggressive care. Like you have to just kind of stop what you're doing and take care of that definitively so that you can feel in control, as Scott said. The patients that make me anxious in the resusc bay are the ones where I'm not sure what's going on. And so I'm applying various treatments, but the patient isn't improving. And that's when it's important to have a program similar to what we've discussed earlier. I developed such a program for myself for this type of situation. I developed a resuscitation heuristic that I promptly, made a video about and posted on EM Updates. This is 10, 15 years ago now. And I go through it all the time when I feel like I'm not in command. It's a mnemonic that has me going through a variety of different assessments and maneuvers. And when things aren't going right, I pull back, I look at that mnemonic, and I remind myself of what the priorities are. And usually that pulls me out of it. The other program is to pivot from type 1 to type 2 thinking. Type 1 thinking is intuitive thinking. And the older you get, the more experience you get, the easier it is to relax into intuitive thinking and trusting your gut. And most of us are pretty good at it, and our gut's usually correct. But when the patient's trajectory deviates from what you expect, the first thing to do is to recognize that the patient's trajectory has deviated from what you expected. You need to pull back from type 1 thinking and start being deliberate. What diagnosis are you missing? Is there another diagnosis? Is there a treatment you haven't considered? What are your assumptions? Often we get a piece of data and that data says to us, oh, this is the diagnosis. You start treating that diagnosis, the patient's not getting better. It turns out that's what I call a decoy diagnosis. You landed on that diagnosis based on one piece of data that turns out to have been false. It led you astray. Pivoting from type 1 to type 2 thinking and knowing when to do that is one of the most important aspects of maturing as an emergency physician and controlling your anxiety in a resuscitation environment.
So, Dr. Strayer, a lot of what you're saying about changing from type 1 to type 2 is situational awareness, knowing when you need to make that transition. Dr. Weingart, any other comments about situational awareness in the resuscitation room? I mean, there's a whole huge topic here of team dynamics and situational awareness, but any top tips you have for us?
Yeah. Emergency medicine is very good at situational awareness during the initial resuscitation. That's what we're built for. And then people want to go off and do the rest of the tasks in the emergency department. And that's a problem. It's why I've so strongly advocated for ED critical care units or a dedicated resuscitation doctor who could be just sticking with those and not having to deal with the exigencies of the waiting room. But one way to counter the problems of having to go see other patients is you got to come back. And in the ED critical care units, I have a phrase, you have to be ABR at all times, always be rounding, right? Like we strongly advocate that when you've finished seeing a resusc patient, you go back and see all the other resusc patients and you actually step to the bedside and reevaluate them on a constant basis. You should just be circling the resusc areas on, continuous loop because the only way to not miss stuff is to be present at the bedside as much as possible. Now, in an ICU, there's a dedicated nurse who's seeing only one or two patients. They're going to do that job. In the emergency department, nurses now have become the real difficult to get resource. So you have to take it upon yourself to be consistently checking in with those patients. And that'll just handle the situational awareness question just by your mere presence. So that could be the biggest tip I'll put out there.
Fantastic. I don't want to get too deep into team-based resuscitation and thinking around that, but in terms of anticipatory guidance, could you just review for us the importance of speaking out loud, what you're thinking, and what that does for your thinking and your team's thinking, and why it's important and how to do it right, Dr. Weingart?
Yeah, sure. So what came out of the aviation industry is the concept of flying by voice. And now pilots are required to do this. They have to be verbalizing, okay, now I'm going to adjust the flaps. And doing that same thing in a resus is game changing. All of a sudden, your mental model is being put out there for the group so that they can understand the things that are happening, what's going to happen next. And then they could find flaws in your judgment. Now, you should actually directly ask for those flaws to be pointed out to eliminate those barriers that Ruben was alluding to earlier. So the question of what do you guys think I'm missing is a game changer in the midst of a resuscitation. So fly by voice, ask what you're missing, stressing closed loop communication. And then I don't know if this is exactly on point, but it's such an important one that I'm going to say it anyway, Anton, is you mentioned the nurse leader that we have during our cardiac arrests. We use a nurse leader for all of our resuscitations in general. And the idea is you only now have to talk to one person. So instead of having to figure out which tech or which nurse you're going to ask to get something done, you just ask the nurse leader and he is at the foot of the bed and you could just say, I need blank. And you look up and you say it and then you go back to doing what you're doing and then hopefully they'll close loop. Okay, you need blank. And then they'll assign who's going to get the blood, who's going to prepare another A-line setup, who's going to do this or that. And all of a sudden, you now have reduced cognitive load significantly. You don't have to remember the name of the various people in the room. You don't have to think about who you're going to talk about, who's the most appropriate person. You've offloaded that to someone who's not actively involved in patient care.
On the situational awareness front, I use the nurses to give time-stamped related feedback to me. So when I leave the room, I will always say, I want to hear when X, Y, or Z is done or back, or when you're back from CT or back from wherever it is that you're going for something.
I can echo that and suggest that although most of us are not going to have the option of this very high level resuscitation paradigm that Scott just mentioned with a nurse leader that will delegate, that's an extraordinary functioning team. But nurses in many environments, in many emergency environments now, are not using their full skill sets. These are highly trained professionals that should be used mostly in an ideal world to give medications and to do patient assessments. But in most emergency departments, they're doing kind of everything for the patient, things that are well beneath their skill set, things that technicians should be doing. One way to push them back into the place that they generally want to be is to be diligent about verbalizing your plans with them, especially in resuscitation cases. It's very easy to forget that the nurse is the one who's spending the most time with the patient. So let them know what the plan is, and that partners them with you to execute that plan with you for the patient.
Absolutely. Now, sometimes when we're in a resuscitation, our mind just suddenly freezes. This happened to me in my early career quite a few times. Thankfully, it doesn't happen much anymore. And I've heard other physicians complain about this as well, is that they're in the middle of a big resuscitation, something goes sideways, and suddenly they just can't think. Their mind just goes blank. And it's one of the worst feelings. Dr. Weingart, what is your recommended strategy for sort of unfreezing in these kind of situations, or to prevent the freezing in the first place?
Yeah, I mean, we call this being in the gray. And when you're there, oftentimes the stressful paradigms we talked about will take you out. You'll free up mental space and you'll be able to start thinking. It's generally because your stress level has exceeded your cognitive capability to process. So that's going to help. ABCs are the most functional heuristic for this situation. Just ask yourself, what could I do to improve the patient's airway, breathing, circulation? And that often will give you your next step. And by perturbing the situation, more things are shaken out. You begin to realize, oh, now I see what this is. Sometimes taking any action, even if it seems silly, hey, let's get a second line, will be enough to move the situation forward. And then I think a really good unfreeze strategy is just take the minute to do a situational recap. So say out loud to the room, all right, here's what we got. The patient's on non-invasive. They're satting okay, but they might have to be intubated because I think they're going to get worse. Their blood pressure's okay right now. We have antibiotics going in. We have good IV access. What do you think we should do next? And now you could offload that decision to the other people around you. And they'll give a suggestion. It might be fantastic. It might not be. It doesn't matter, because now your brain is being given a moment to start processing all of the things you just said, to allow time for something to occur to you as to what the next action is.
I've heard that referred to, maybe by you, Scott, as a tactical pause. When you feel like you're getting overwhelmed, take a tactical pause and just summarize the situation out loud. Just the process of verbalizing the situation is often highly clarifying. And then the other thing I would add is that when you're really stuck, that is the time to bring in another doc and summarize the situation. Sometimes someone comes in, fresh set of eyes, ears, fresh brain. You summarize the case to them. In the times that I've done that, half the time, by the time I'm done summarizing the case to them, I know the next step just from summarizing the case to them. And then the other half, it's fairly obvious to that other person what to do, because they're a fresh set of eyes, ears, and brain that can help you out with your decision making.
Yeah, I can't emphasize enough the value of talking out loud, not only just for your team member, but I find when I talk out loud and I review, or I have a tactical point where I then review and then what we're going to do next, it's almost like you're talking to a colleague. When you talk out loud to yourself, I find that incredibly valuable.
I think there's power in the recap as well in the room, partly because sometimes things aren't going well because what you think has been done actually hasn't been. You've said for something to be done. You think it's been done, you've been busy doing something else, and it actually hasn't. So, having that tactical pause to, okay, tell me what we've done so far. What's been given? What doses happened? How much blood has gone? Whatever it is, get the whole recap done, and then find out, oh shit, we didn't actually do whatever it is that's critical.
Where is that blood?
Right. We didn't give steroids to this adrenally insufficient patient. Whatever it is, it's, you will catch mistakes that way too.
Before we head into the final lap of this podcast, just a quick announcement for those of you who attended the EM Cases Summit in November 2024, and I suppose for those of you who unfortunately missed it. I'd like to sincerely thank the 25 or so incredibly talented world-class speakers for their mind-blowing talks, panel discussions, and the procedural demonstrations. I also want to thank the more than 600 registrants from more than 30 countries who participated in the Q&As, the symposiums, and the simulations in such an engaging way. It really made the summit feel like something really special. So thank you so much. For a limited time, we've made available all the main stage talks in a video streaming package, not only for the 2024 summit, but also for the 2023 and 2021 summits at a discounted price. So even if you were at the summit in November and want more summit, you can purchase streaming packages from our vault, again from the 2023 and 2021 at a discount. If you missed the summit, we've also got you covered. Just head over to emcasessummit.com. So not the main EMCases website, but the website dedicated to the summit. That's emcasessummit.com, and you can purchase video streaming packages there. All right, now back to the final lap of How the Experts Think.
All right, fantastic. So we've talked about how to prep for the recess. We've talked about what to do during the recess. I want to talk about the post-recess recovery, and we touched on this a little bit already. You got to transition back to seeing the rest of your ED. And sometimes you do a resuscitation that's, emotionally very taxing. It could be a child. Maybe it didn't go well. Maybe you've struggled for whatever reason. How do you recover after a big resuscitation that takes a huge amount of your decision-making facilities and has been emotionally draining so that you can actually continue to be sharp and agile on the rest of your shift? Dr. Strayer?
Well, in contradistinction to Scott, I love the fact that I can pick up an ankle sprain after I do a big resus case. And I find that to be the most therapeutic, frankly. So after like a talk and die patient, which I think are the ones that really get to us the most, picking up an ankle sprain is it's just an absolute joy. So when you find yourself in that mindset of being stunned by something horrible that's happened on your watch, lean into the softer cases. And then when you go see that ankle sprain, focus on being present for the ankle sprain. What's going to happen is you're starting to take a history from this perfectly well person that tripped and fell and now has a sprained ankle, and your mind drifts back to the traumatic arrest that you just managed on a young, healthy person. Again, mindfulness practices really help here. Allow those intrusive thoughts in and then escort them out and refocus on the ankle sprain in front of you. I find that person to be highly therapeutic and allows me to get back into my groove.
Yeah, do the same thing. I think there's a role also for a debrief, for the worst of the worst. I think you really should make time for that. It's not necessary very often. Honestly, I know a lot of groups are doing it more and more and more. There's not time for that. But for the really bad ones, you should have a debrief and make the time for it at the time, not the next day.
Yeah, I did an entire episode on this. I think it's such a incredibly important point to get right. You're going to have a huge parasympathetic backlash, and you have to be prepared for that. Your brain is not going to be ready for the next difficult situation until you start fixing your mental state. So some of the things to do are, if you can, grab a snack. Thinking exerts a lot of caloric consumption, and grab something to drink. If anything's gotten on you, it could be a huge washing of your hands spiritually to just change your scrubs. I always have like a bunch of scrubs available, and, spending the rest of the shift with blood all over you, it's just not great. But just from a mental process, I find there's something therapeutic to just changing your clothes. And then I actually love debriefs always for everything. Now, Mike, you mentioned the time. I'm not talking an extensive, even 10-minute debrief. That's way too long. We like to debrief for just a minute or two, especially if there's teaching points or I want to actually discuss with the nurses, hey, was there anything we did that you guys had any questions about? I think it's just such a valuable use of those couple minutes. And I don't like the, go off amongst yourself and regather. For many of them, that takes too long. You're absolutely right. But just a minute or two right afterwards. And we debrief all of our group procedures. For instance, airways. Every airway gets a debrief where we just go over it. Hey, is there anything, because it's the learners doing the intubations at my shop. We go through, is there anything you could have done differently? Because the worst situation is when they'll get an airway, but their technique wasn't good, because now they will internalize that bad technique because they've been subconsciously and consciously rewarded for it. So central line, same thing. Like any kind of procedure, we do a debrief in real time, just because I think it's so valuable from a teaching perspective, but also from releasing that huge surge from a major resuscitation.
Yeah, just two things I'd like to add. One thing that I found really helpful is in those cardiac arrest patients that you can't get back is the 30 seconds of silence around the bed for the whole team in front of the patient to think about who this person was that you just tried to resuscitate. And then the other thing is when things do go well, just a positive statement to your team. We just saved a life. Congratulations, guys. You all did a great job and we did it together. Another life saved. And that might put you in, the mood to then want to go see new patients. So again, it's that communication that's so important. Well, that about wraps it up for this part one of our two-part podcast on how experts think. Hope you took away some strategies and ways to help improve how you think as an emergency provider. And I hope you've reflected a bit on what you do just before a shift, how you sharpen your mind during a shift, and how you think before, during, and after a resuscitation. In part two, it even gets better. We'll discuss with these fine gentlemen how master clinicians think in complex non-resus cases and what we can do outside of our shifts or after our shifts at home to improve the way we think and perform in the ED. For the complex non-resus case, we're going to discuss things like how the master clinician thinks about history taking, physical exam, how they develop a differential diagnosis, test ordering, test interpretation, cognitive debiasing, how they use heuristics, which we've mentioned already, decision-making around treatments, and how to best document to improve your performance. We'll elaborate on that too. And then outside of your shift, we'll touch on all kinds of performance-enhancing strategies, everything from stress inoculation training to strategies on managing adversity, to decision-making journals, to deliberate practice and mental rehearsal, and more. So thank you so much, gentlemen, for your brilliant insights into how the experts think. Looking forward to part two.